All right. The floor is yours. Thank you
All
so
right.
much.
Great. Yeah. Thank you for your flexibility. And hi, everyone. Sorry I can't be there in person. First time doing this virtually. I guess COVID years, we did it virtually, I suppose. But yeah, spare you all from this lovely stomach virus my family seems to continue to share for the better part of a week now. But so if you hear footsteps, I'm in my lovely like pseudo basement office thing. It looks like I'm actually in an office. This is just my lovely 70s drop ceiling from our house. So yeah, this is where I'm at, but I'm right above or right below the bathroom. And so my son, still is having some issues. So you might hear some feet going back and forth or some toilet flushing, which I apologize. That is the way of virtual presentations. But nonetheless, we'll get started here. So yeah, I've done this lecture a couple of times, but just as an introduction, my name is John Beggart, and I'm one of the clinical practice faculty at the School of Pharmacy. So I teach in our therapeutics curriculum on these topics, mostly the management of chronic cardiovascular diseases. So much of the medications we're going to touch base on today, as well as the management of diabetes in our curriculum as well. So many of the cardiovascular issues tie hand in hand with diabetes. And that's largely what I practice in as well. I'm a clinical pharmacist at Virginia Garcia at the Cornelius Clinic. So I see patients there under collaborative practice agreements to be able to prescribe medications, order labs, do all those types of things, manage the medications for that patients are on chronically, to open up some time for providers to see patients for more acute issues. So much of my time is in this realm, but definitely not thinking about the dental implications so much. But this is what this lecture is mostly going to focus on for you is you're going to see many of these medications in practice if you're talking with your patients and getting a med review by chance, getting an idea of what they're on before you go in and work on their mouths for whatever reason. So you'll definitely see these. And so the take-home points will really just be, what do I need to be thinking about from a dental perspective? So we'll just go ahead and jump right in. I think these objectives are pretty accurate, basically just being able to recognize the medications and what they're being used for, their therapeutic effects, and then particularly adverse effects or specifics that relate to oral implications. So that's what we're going to talk about. And the main disease states we're going to cover as it relates to the drugs, which I think you've already had an overview of these disease states. That may have been the quiz maybe that you guys just took, or at least historically you've kind of gone through some of these physiologic processes that's going on with these diseases. But we're going to talk about antihypertensive agents, which I think I'm frozen. Okay, I'm back. I think I was frozen.
We heard you the whole time.
My voice was working, but my face was making a weird face. So yeah, dyslipidemia or hyperlipidemia agents, anti-anginal medications, or for those that have cardiac, coronary artery disease or ischemic heart disease. You hear it termed a variety of different ways. And then anticoagulants and antiplatelets, which will impact bleeding. So, just as most of these medications kind of make sense in their name. Obviously, we're lowering blood pressure with antihypertensive agents. We're lowering our lipids and cholesterol levels, preventing atherosclerosis with our hyperlipidemia agents. Anti-anginal medications are just providing more oxygen to the heart to prevent ischemia, tissue death, ultimately down the line, preventing any heart attacks. And then anticoagulants to prevent any clot formation that could lead to stroke, heart attack, DVT, pulmonary embolism, things that could really be deadly or impactful to patients if they occur. So we're going to start off with blood pressure first, and how our body regulates blood pressure. Just a quick overview. I like to think about blood pressure in terms of a math equation. Some people don't like math, but I think it makes a lot of sense when you look about how you change components within this equation. to impact the product. So we have cardiac output, which is largely impacted by heart rate and contractility. And then we have peripheral resistance, which is basically the resistance at which the blood needs to, the resistance the blood has going through the vasculature. And that's impacted by blood volume, largely. How much liquid and water is in the blood pushing out on the vessels. If there's more in there, you get increased pressure. So if you increase any of these components within this equation, your end product is going to be higher, hence higher blood pressure. So our targets for our medications are going to be lowering components within these equation that lower cardiac output or lower peripheral resistance to hopefully lower our blood pressure. And I can't remember where I've got all my circles, but that's kind of where our body is normally functioning to maintain blood pressure. Now we're going to take advantage of these areas with our medications to impact and lower our blood pressure in our hypertension patients. I think.
Sorry, I forgot to mention in the beginning that the students ask lots of good questions. So do you mind if I periodically interrupt you if someone has a question?
No, yeah, please go ahead.
Okay.
Yeah, usually, yeah, go for it.
Okay, Saba has a question. What is it, Saba? Oh, so he's basically, the other thing is we haven't gone over the pathophysiology quite yet. So that's we're kind of jumping the gun a little bit. But so he's just saying that the amount of blood volume, the amount of blood in the veins and the arteries, or in the arteries, sorry, if there's more blood in there, you're going to have more pressure on the walls. So that's high blood pressure. Or if the heart is pumping harder, you're going to have more blood volume, and that puts pressure. So both of those elements can increase blood pressure and make for high blood pressure. She just wanted it repeated again, but feel free to repeat it even better than I just did.
Yeah. That's exactly, what it is. We have blood, so and it's liquid, obviously, but we don't think about it changing in volume. There's blood cells in there that carry oxygen around, and that's what we need. But it also can become richer or less rich with just basically water, depending on, how our body needs to perfuse our organs and whatnot. And so it becomes more full to increase blood pressure in order to adequately oxygenate our tissues and deliver resources and nutrients that our tissues need. And so our body naturally adjusts this, and it might make a little more sense when we talk about this pathway. So this is the renin angiotensin aldosterone system pathway. This is one of the big players in controlling our body's blood pressure. This is regulated largely in the kidneys. So the kidneys are a big measurer, if you will, barometer of what our blood pressure is. And if it's too low or too high, it will adjust through a variety of these different mechanisms through this angiotensinogen to angiotensin 1 to angiotensin 2 pathway right here. And so angiotensin 2 goes up and can do a variety of different things. All of these things on the right-hand side here will lead to an increase in blood pressure. So the sympathetic tone, so that is increasing the release of epinephrine or norepinephrine, which I'm sure you all are familiar for dental implications in oral procedures in terms of being a vasoconstrictor. So depending on the receptors that epinephrine and norepinephrine bind to, that can constrict or dilate blood vessels. Constricting blood vessels will make that opening smaller. If we think about blood vessels as just pipes within our body, the smaller the pipe, the harder it is to push something through it, the liquid through it. You'll have to push more forcefully. And so that needing to push more forcefully is causing more pressure. And so that will increase blood pressure. Sympathetic tone also can increase heart rate. And if we think back to cardiac output, the more cardiac output we have, the higher the blood pressure we have. And so increasing heart rate, increasing contractility, how hard the heart contracts, will increase blood pressure. Sodium resorption and aldosterone secretion wherever sodium goes, water will follow. So if we pee out sodium, or if we release sodium from our body, water will follow it and will diurese. Hence why we use medications called diuretics, which we'll talk about, to lower our blood pressure. But when our blood pressure is low, or if our body wants to raise our blood pressure for some reason, it will hold on to sodium, and then that means we hold on to water, and that increases our blood volume. So in that pipe, now we have more voluminous blood within that pipe, causing more pressure on the outside and increasing our blood pressure that way. I already mentioned vasoconstriction, smaller pipes, more pressure, and then sodium, other mechanisms for water resorption to increase blood volume. So this is all our body's natural system at which it regulates blood pressure. And when all of these sites are activated through angiotensin 2, that causes blood pressure to rise. Now we're talking about lowering blood pressure. So we're going to stop this flow, this pathway, at various points in order to lower blood pressure in our patients with hypertension. And so we'll talk about a few classes of medication that stop a couple areas within this pathway, block angiotensin 2, or stop the conversion of angiotensin 2 in order to lower blood pressure in our hypertensive patients. So our first class of medications that we'll talk about for blood pressure management are our diuretics. So these work primarily in the kidneys. And as we were just talking about blood volume, these work by increasing the loss of sodium. And so then the water follows the sodium out through the urine. So folks, when they start these medications, they'll have an increased amount of urination, and then that will in turn decrease blood volume and lower their blood pressure. So there's three classes that you'll likely see. Thiazide diuretics are going to be the most common ones used for blood pressure management. And so hydrochlorothiazide, or HCTZ, is probably the most common one, but I would say chlorthalidone is becoming more common because this one actually has better evidence to support its use for cardiovascular, reduction of cardiovascular events and improvement of mortality. Loop diuretics are those that are going to be used less for hypertension and more so for heart failure. So these are really good at diuresing patients. They get off a lot of fluid, and our patients with heart failure start to really retain a lot of fluid, either in their lower extremities or in their lungs, causing congestion. So we take off that fluid so they can breathe better and have less symptoms. And then we have our potassium-sparing diuretics, also known as aldosterone antagonists. So, and then we have other potassium-sparing diuretics, but I'm not going to talk about those because they're not really used for hypertension management. But the most common one you'll probably see is spironolactone. This one's technically used for resistant hypertension. So if you see somebody on spironolactone, they'll either have resistant hypertension, so they'll be on multiple hypertension medications, first-line meds, but they still have a hard time getting to goal, and then they'll be on this med to try to get them down a little bit more, or they'll have heart failure. And this is a core therapy for heart failure management. It's sometimes used for other indications as well, but cardiovascular-wise, those are the two reasons you might see spironolactone. As far as dental implications go, the lichenoid reaction is probably the biggest one that you would be considering about or thinking about, in that, they might develop this kind of oral lichen planus in their mouth. This can occur at any time in treatment. It doesn't necessarily occur right after initiation. It can occur years later. It is an immune response. And so oftentimes treatment would be to discontinue the medication. But if for some reason you can't, say they're on a loop diuretic because they're fluid overloaded and they need that loop, then they might need to treat with corticosteroids to kind of blunt that immune response and hopefully clear that up. Electrolyte imbalances, you're likely not monitoring labs for electrolyte levels, BMPs and things like that, but it can negatively decrease electrolyte levels too much, particularly potassium and sodium. And that can lead to any number of issues. Low sodium can lead to dizziness or confusion, and low or elevated potassium levels can lead to arrhythmias. So it's important to keep an eye on making sure you're not over diuresing. The other thing, dental wise, that's not on here is you could over diurese, meaning you take off too much fluid, and that would lead them to be dehydrated, which can lead to some dry mouth, and could definitely impact oral health and development of bacteria and other types of things growing in there. So we try to not over diurese. That means we're causing problems from a medication that we're using to try to solve another problem, but it can happen. Any questions about diuretics?
It doesn't look like it. Nope.
Okay.
You're good so far.
So definitely going to see these on your patient with your patients who have hypertension. Beta blockers, you may or may not see them as frequently for hypertension. These aren't one of our first line medications for just hypertension management, but they definitely are used for other cardiovascular conditions, heart failure, post myocardial infarction, those types of things. And so these work in that sympathetic tone. So I said where epinephrine and norepinephrine is involved to increase heart rate and or vasoconstrict. These work mostly in the heart. Well, we'll talk about where they work here in a second, but they basically block norepinephrine and epinephrine from binding to beta receptors. And that has various downstream effects. So we have our cardioselective beta blockers, which are the beta-1 antagonists. So that's some examples here: metoprolol and atenolol, probably the most common ones you'll see. The nice thing about this class is they all end in olol. So if you see OLO or OLOL, that means it's a beta blocker. So our non-selective beta blockers, this is not an all-inclusive list, but the most common one you might see is propranolol. This one might be used for hypertension management, but it's often used for other indications like stage fright or anxiety, migraines, tremors, things like that, because it can stop some shakiness that can occur. It gets into the brain a little bit better. And then we have our mixed beta and alpha blockers. So the most common one being carvedilol. But if you're working in a pregnant female who has hypertension, she might be on labetalol, which is one of our preferred blood pressure management options in pregnancy. And so as far as dental hygiene goes, and I guess I'll wrap in a wrap-up slide, I'll talk about this, but I can mention it now. Just be aware that when we're lowering blood pressure, you could always have hypotension, right? So the blood pressure goes too low. So dizziness or something like that could always present itself, especially if somebody has postural hypotension, meaning they're seated or laying down and get up too quickly, and gravity takes hold of the blood and basically pulls it out of their brain, and they get a little bit dizzy, woozy. Now that most often will only happen when new drugs are initiated and their body hasn't gotten used to it. Or if they're elderly, as we get older, our blood vessels stiffen. And normally when we get up from a seated position, our body compensates for that movement and needing to maintain blood pressure to the brain by constricting the blood vessels. But in elderly, those don't quite constrict as much. And so as they stand up, the blood vessels stay about the same size, so the blood pressure drops, and then they can get dizzy and have syncope, faintness. So you want to make sure they're getting up slowly. And that can be maybe even more potentiated with beta blockers, in that it's impacting the contractility and the heart rate, how fast the heart's beating. And a component to compensate for getting up quickly is your heart rate will increase. But if you're blunting how fast your heart beats because you're on a beta blocker, you might not get that increased heart rate as quickly from a seated or a lying down position. So just making sure they get up slow, take it easy for a moment before they stand up will ensure that everything kind of catches up to itself. But in terms of other dental hygiene implications, patients might be more sensitive to epinephrine if they're on a beta blocker, particularly, non-selective beta blockers. And so I've got a little demonstration here to kind of outline that. So if we have all of our adrenergic agonists, epinephrine and norepinephrine, and we have all these receptors in the system, we have beta 1, forget when things move. Beta 1 is in the heart. That's easy to remember because we have one heart. Beta 2 receptors are in the lungs. We have 2 lungs. And then alpha 1 receptors are in the vasculature. And so when they bind normally, when they're not blocked, beta 1 receptors will increase heart rate, increase contractility, hence increase blood pressure. Beta 2 will relax smooth muscles. So that will be either in the lungs. So a common, can you guys think of a common beta 2 agonist you might be aware of that helps, works in our lungs to help us breathe when we inhale it?
Albuterol.
Yep, albuterol.
I said, good,
Yep.
learned it.
Yep, albuterol. So that is a beta 2 agonist, and so that will open up our bronchioles and allow us to breathe. And that's just taking advantage of our body's natural mechanism. And then alpha receptors are kind of a counter regulator. So beta 2 relaxes blood vessels, alpha 1 constricts, so that keeps everything in balance. Now, when we have a beta 1 antagonist like metoprolol, for example, we block this beta 1 receptor. Now, for management of heart conditions like hypertension or controlling the rate in atrial fibrillation or heart failure, that's a great mechanism. We want that to kind of work just in the heart and nowhere else. And so epinephrine can bind in other receptors and not have any, not be blocked at all and do their normal thing. Now, if we have a non-selective beta blocker like propranolol, they block both beta 1 and beta 2. So what the issue comes about when epinephrine is utilized, and now this is more so not so much of a concern when you're talking about the volumes of epinephrine that you use in dental implications. However, I've looked at studies that have looked at how does the blood pressure change in patients that are on beta blockers when they do use oral volumes of epinephrine, and it's very slight, maybe slight increases, nothing that's really concerning. But nonetheless, it's important to be aware of if somebody is on a non-selective beta blocker, just keeping an eye on blood pressure, making sure that if we are utilizing epinephrine in our procedure, even if it's just 1 to 2 cartridges, and I think your guys' ratios are like really small, like just not very much to impact many things systematically. It's just mostly at the site. But nonetheless, just keeping an eye on blood pressure, making sure they're not shooting up too high, because there have been case reports of other instances, not dental, but where epinephrine has been given at higher systemic doses, and the blood pressure rises to 200 millimeters of mercury systolic, which is hypertensive urgency, and can definitely increase someone's risk for a heart attack. So really only a problem on non-selective, right? Because we're blocking this beta 2 receptor here. I'm pointing with my finger. Let me use the mouse. We're blocking this beta 2 receptor. So now epinephrine binds to this alpha 1 receptor and has unrestricted. There's no counterbalance of vasodilation here from this beta 2 receptor. So it's pure unrestricted vasoconstriction. And that's what leads to elevated blood pressure. So dental implication, maybe. in the small enough amounts, just keep an eye on blood pressure. And you're doing that anyway. When somebody's going in, you're checking a blood pressure, especially if somebody has a history of hypertension or other cardiovascular conditions. But just something to be aware of when you get a med rec and you might see propranolol. That's non-selective. Maybe I should keep an eye on their blood pressure a little bit closer. Any questions on the beta blockers, the alols?
Oh, yeah. Mm-hmm. 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 Yeah. So the question is, if somebody has anxiety and they're on a medication like propranolol, is it safe to or would it be appropriate or safe to prescribe them some kind of an anti-anxiety medication or an oral sedative to kind of, are you thinking like counteract it, Irene? Is that what you're thinking, to keep their blood pressure down or something? How would that work?
And they were already on a beta blocker?
Yeah.
Well, yeah, I mean, if they're on a beta blocker for anxiety, just like generalized anxiety disorder, somebody might be on propranolol. But if they have significant risk for panic attacks or something in the setting of the dental chair, then prescribing something like short-term as needed benzodiazepine or something, that might be done. And it doesn't have an issue, no interaction with the beta blocker. And
if they're on the beta blocker for blood pressure, I think that's what she was thinking, that they would actually be on it for blood pressure, not for anxiety. But you're saying it would be fine either way.
Yep. Yeah, there's no interaction. If anything, it would help to keep their blood pressure from being too elevated. Because in the anxious state, you could definitely see an increased risk in blood pressure. And if somebody's already hypertensive, and anxiety is just going to increase that. So yeah, they might need it, and that's fine.
Okay, thank you.
All right. So the next class of medications we have are ACE inhibitors. These all end in pril. So if we think back to that RAS inhibition, RAS pathway that I showed earlier, this inhibits ACE, which is ACE, angiotensin converting enzyme that inhibits the production of angiotensin 2, which had all those downstream effects to increase blood pressure. So these are definitely first-line options. You will for sure see folks on these medications. Not an all-inclusive list by any means, but enalapril, definitely lisinopril is probably the most common ACE inhibitor. Benazapil, ramipril, quinapril. There's a whole bunch out there. They all work the same. Nothing really different between them. As far as dental implications go, there aren't really that many. And I have a graphic here I should probably go through. So after I talk through, inhibits ACE version there. I have a picture of angioedema here only because it's involved in the mouth, not because it necessarily has anything to do with what you're doing dental procedure wise. But this is an effect that can happen due to the inhibition of ACE. This leads to an increased production of what we call bradykinin. And bradykinin is a vasodilator. It actually helps to lower blood pressure more. It has some beneficial effects, but some negative effects can be it causes a dry cough. So folks cough, not because they're sick, they just cough. It could be pretty annoying and they choose to stop the medication. But a more significant adverse effect can be angioedema. So this picture here is maybe not the best picture, but you can see how his tongue is swollen and enlarged. This presents almost like an anaphylactic type reaction. It's not an anaphylactic response, but it does lead to swelling of the face, the lips, the throat, difficulty breathing, and definitely life-threatening. And so you want to not use this medication anymore if they have that, for sure. But again, not something that will happen because you are working on their mouth. I guess if anybody, though, is on an ACE inhibitor and you start to see unexplained swelling going on, if you're in there, maybe ask what's going on and I don't know, they could be having an allergic reaction, or maybe they're getting to the initial stages of angioedema. But this is very rare. It is a rare condition, happens more frequently in African Americans, but nonetheless still really rare. The other adverse effects, hyperkalemia, so could cause arrhythmias. You have to monitor for electrolyte levels. And pregnant women, women that are considering becoming pregnant, childbearing age, or even thinking about pregnancy in any way, shape, or form should not be on these medications, as that they are not necessarily provide birth defects, but could be fatal to developing baby. So they should not be used. So these are ACE inhibitors, one of our core therapies for blood pressure management. Next one is ARBs. I talk about them close together because they're basically the same thing. These are angiotensin receptor blockers. They all end in sartan, so losartan, valsartan. The difference being, rather than inhibiting ACE, they now block the angiotensin 2 receptor. So boom, falls in there, can't activate, and they essentially have the same effect. It just changes, the differences in the med just change where within the stream they block angiotensin 2, either block the formation or block the receptor. The only difference being, since they don't block the formation of angiotensin 2, they don't increase the levels of bradykinin. So the risk of cough and angioedema are pretty much non-existent. There are some maybe cross sensitivity studies that show you might still get cough or angioedema, but it's often what we might switch to if somebody has a negative effect from an ACE inhibitor. Say they can't tolerate the cough, we switch them to an ARB. And so very common blood pressure meds, very commonly first-line therapies for heart failure management, also first-line therapies for patients with chronic kidney disease, in that they work primarily in the kidneys and help slow the progression to end-stage renal disease, which is definitely a good thing. But dental implications outside of lowering blood pressure, not very many specifics here. Any questions on ACE and ARBs? One more class we're going to talk about for hypertension.
It doesn't look like it. No question.
So our next class, there's technically two classes here, but they're calcium channel blockers. And so these dilate the arterioles, so they open up our pipes, lower our blood pressure, pipes being our blood vessels, and they also reduce heart rate. Most primarily the non-dihydropyridines. So that's what DHP means, dihydropyridine. So you'll either hear these referred to as non-DHPs or DHPs. The DHPs all end in P-I-N-E, which is not pronounced pine, it's actually pronounced peen. And so the most common ones we would see are amlodipine, felodipine, or nifedipine. These work primarily in the blood vessels, opening up the blood vessels. Verapamil and diltiazem, which are non-dihydropyridines, they work like beta blockers, and they actually slow the heart rate down. So they have different indications, which we might use them sometimes, but they're definitely first-line options for blood pressure management. I'd say if you're just seeing a patient on one of these, or just using one of these classes of medication for hypertension management, the dihydropyridines are going to be the most common ones you see. They tend to be the most tolerable. Non-dihydropyridines, they're great too, but they have some other issues adverse effects wise. And so these are usually what you'll see. Amlodipine, probably the most common one that you will see for blood pressure management. Dental implications, though, definitely something specific to your field is gingival hyperplasia. Most commonly seen with nifedipine within the dihydropyridine family, but all of these can potentially develop gingival hyperplasia, so overgrowth of the gums. And so the best treatment for that is really just discontinuation and letting that kind of resolve. That being said, if there's some indication needing them to be on it long term, I've seen where surgical resection needs to happen in order to kind of re-expose the teeth from this overgrowth, which I'm not an expert on this, but I've seen that the biggest issue with this is not only like how it appears. Obviously, people don't like that appearance, but that it also can impact the ability to adequately clean the teeth, and then it can kind of lead to decay and whatnot. And so not good to have all around. But if this does develop, definitely might consider switching class of medication. Nifedipine, the one that I said is most commonly seen, this develop is not the most common agent used. And so I don't think that because it has a higher risk for gingival hyperplasia, I don't think that's why it's not most commonly used. There's an IR formulation of nifedipine that causes bad issues, and so that's probably why nifedipine's not really used. But nonetheless, it can be prescribed, and just keep an eye out for it if they start getting tissue growth. It is a class-wide effect, so all of them could potentially develop this, though. Other adverse effects, there aren't any electrolyte abnormalities or things to concern yourself with. It'll lower blood pressure, so you always keep an eye on that hypotension risk. So as far, any questions on the calcium channel blockers?
Not yet. Oh, wait, maybe there is a question. Hold on. Yeah, go ahead, Sally. The question is, do both the non-DHP and the DHP reduce heart rate, or is it only one of them?
It's actually only one of them. The non-DHP reduces the heart rate. The DHPs can actually increase the heart rate. You can vasodilate, and when you vasodilate, there's a receptor in your heart that senses that, and your heart doesn't necessarily like drops in blood pressure. So what it will do is it'll cause rebound or reflex tachycardia, and in order to compensate and try to bring that blood pressure back up. So you can actually see an increased heart rate in dihydropyridines, and that can be something that you need to consider. Maybe not you, but if you're managing somebody with angina or ischemic heart disease, where elevated heart rate can lead to more pain, more anginal symptoms, then the dihydropyridines might not be the best option. But on the flip side, they can actually relieve you anyway. Not the place. So yeah, definitely.
There's always more to know on topics.
Yeah. So non-dihydropyridines definitely primarily decrease. You can see an increase with DHPs. So as I mentioned, orthostatic hypotension is going to be a big thing you're always going to keep an eye on for folks with hypertension, particularly as they get in advanced age and if they're newly started on a medication. NSAIDs, if you're prescribing them for pain after an operation, can blunt the antihypertensive effects of medications, particularly diuretics and ACEs or ARBs, in that NSAIDs can lead to fluid retention, which can blunt the effects of a diuretic, and can lead to vasoconstriction, which can particularly blunt the effects of ACEs and ARBs, because the vasoconstriction usually occurs in the kidneys where the ACEs work. Short-term use usually isn't really a big factor. It's long-term chronic use where you start to see blunted effects. But some folks are on NSAIDs long-term, whether they should or should not be. Likely they probably shouldn't be, but they take it every day anyway. And so they might not see adequate blood pressure control. And then the lichens reaction, most commonly seen with the diuretics, as we mentioned, somewhat with ACEs and beta blockers, but definitely more so with the loops and the thiazides. All right. So now we have our drugs of therapy for angina. So this is where we don't get enough oxygen to the heart and we start getting pain. And so this is due to ischemia, lack of oxygen causing pain, built of lactic acid. in the muscles, similar to if you're working out and you start getting leg or muscle pain. Same thing's going on in the heart. So we're trying to dilate our coronary arteries to supply more blood, reduce the heart rate to decrease the workload, and control any cholesterol levels that are elevated to stop atherosclerosis from developing, which narrows the arteries, restricting blood flow, and can ultimately lead to ischemic heart disease and potentially myocardial infarction, which leads to tissue death and possibly death, obviously, of the person, depending on how much of the heart tissue dies. So we try to prevent this from happening. And so organic nitrates are our go-to when we're just talking about symptom management. Now, there's other medications we use, many of the ones we already talked about, that help prolong years of life for patients with ischemic heart disease. Nitrates are just for symptom management. They just help to control anginal symptoms and make people feel more comfortable. So that's our nitroglycerin, our isosorbide mononitrate, and dinitrate. These vasodilate, and similar to like our blood pressure medications, they dilate, but they largely relax the coronary arteries in the veins to decrease workload of the heart to pump blood out and also to increase the blood supply going back into the heart. Both of those decrease the chances for developing symptoms. Dental implications that might arise, again, is hypotension, specifically with these in the short term, or if they're taking as needed nitroglycerin for any reason. Those are like the sublingual tablets where they just put them in their under their tongue. If you've seen, maybe folks have little bottles that have these little pills that if they start getting symptoms of chest pain, they pop them in their mouth, and that alleviates the pain. Isosorbide mono and dinitrate, those are long-acting nitrates that are taken scheduled on a daily basis. They do basically the same thing. But the as-needed nitroglycerin can cause a significant drop in blood pressure pretty quickly. Might lead to hypotension and headache. Some folks may need to take these if they get significant anxiety around the dental chair, and that anxiety leads to an elevated heart rate that would then lead to developing of chest pain. You can use as needed nitroglycerin for, say, exercise-induced angina. Like if people know I need to exercise to increase my cardiovascular health, but every time I exercise, my chest hurts, folks can be prescribed as needed to prevent that from developing. And so they may need that for in the dental chair as well. It can also cause dry mouth. So that would, again, lead to down the road dental procedure or dental issues. So for you guys, when you're working with somebody that has maybe ischemic heart disease, getting an idea, do they have nitrates? Having them available while they're undergoing a dental procedure is important in case they do start having any chest pain or complications. Making sure that they are calm is also a good thing. So don't be scary, especially if they are anxious about being in the dental chair, because that might induce some of that chest pain. Making sure that they have oxygen available as well, because that will help to reduce anginal symptoms, in that if you increase their blood oxygen, then they're able to more adequately oxygenate tissue. So if they're starting to have symptoms, putting in some cannula for oxygen might be beneficial for them. And then the other options, as I mentioned, we already talked about, that are used for the management of angina, are beta blockers and our calcium channel blockers. Questions for the nitrates?
I don't see any questions.
So our statins are the lipid medications that you'll most commonly see for decreasing our bad cholesterol, so our LDL, that leads to atherosclerosis and plaques to develop. So they all end in statin, which is easy to remember, which is why they're called statins. And the most common ones you'll probably see are going to be atorvastatin and rosuvastatin, maybe simvastatin. That's definitely one of our older ones. But Lipitor and Crestor are high intensity statins. And so they have more flexibility in use. They don't really have dental implications. They don't really have a lot of side effects in general. The main thing being that they might present, people might get myopathies, muscle pain. In worse scenarios, they might get rhabdomyolysis, which is a serious condition of accelerated breakdown of muscle tissue, but that's pretty rare. But not a lot of adverse effects from these medications. Some folks say that they should be in the water, that along with metformin, because decrease inflammation and reduce cardiovascular events and all types of things. Obviously, that's never going to happen, but it just goes to show that they're pretty tolerable, and lots of folks are on them. So you'll definitely see statins, but not many things for you to concern yourself with dental wise.
Is it too complicated of a explanation to say why it lowers LDL but raises HDL? Is that more than we would ever need to know?
Mechanistically, through the HMG-CoA reductase inhibitor, it's gonna it impacts how well. So all cholesterol is created through like the same backbone, right? Through total cholesterol, HDL, triglycerides. So it just impacts the metabolism at which like LDL is being formed and then kind of shunts over to the, similar to like how elevated levels of like bradykinin develop when you're inhibiting the ACE enzyme. So you kind of just see different pathways get shunted over to. It increases HDL, which is a secondary target, or reduces triglycerides. However, those are never really our main goals, because we can't identify that doing those things outside of reducing the risk for pancreatitis with having lower triglyceride levels. We can't really pinpoint why doing those things are good. We've tried to use other medications that raise HDL to see if it reduces mortality or reduces cardiovascular events, and then we can never find it, and we can never. Niacin used to be a really common agent used for raising HDL, and we thought that was going to be the savior to try to also reduce mortality, and it actually caused worse cardiovascular events, and so niacin really isn't used anymore, and LDL is our primary target. We know that's bad.
Yeah, interesting. Thank you.
So that was statin. So then the last indication that we're going to talk about, kind of lumped together, are anticoagulants and our antiplatelets. I'm talking about them together because they work and impact bleed risk. However, they work very differently in terms of their coagulation cascades. So we have, obviously, we get cuts, we get injuries, clots form through activated platelets and other clotting factors. And so that's a natural process. However, those can be troublesome at times, depending on why they're being caused and where they're being formed. So if folks have atrial fibrillation, for example, or mitral regurgitation in their heart, blood is swirling back and forth, developing clots on those valves. Those can dislodge and go up and cause a stroke. They can cause DVTs if they're formed in other locations in the body, which can lead to amputations, can cause clot formations in the lungs, which can lead to pulmonary embolism, which can be very deadly. And so depending on where the clot forms and what procedure you had or what issue you had, you may be on antiplatelets or anticoagulants to prevent the formation of those potentially deadly clots. So antiplatelets, most commonly, or our oldest, is aspirin, but we also have our other agents, COX-2 agents, that are clopidogrel or prasugrel or ticagrelor, which are becoming more commonly used. I have clopidogrel in red, but some of the other agents are increasing in popularity due to more evidence that's coming out for their use. So you might see patients on one or both of these agents simultaneously, dual antiplatelet therapy, after maybe having a stent placed, for example, or any type of revascular surgery where they rerouted the heart's coronary artery bypass graft, for those that were maybe having significant occlusion or blockage in their coronary arteries. And so this just helps to allow the blood to move through, decrease the potential for any clot formation. However, it's going to increase somebody's bleed risk. And so if working in somebody's mouth, it's definitely something to be aware of, in that they might bleed for longer. However, for antiplatelet options, as well as anticoagulant options, discontinuation of them is usually not needed for oral procedures, and that the risk of developing a clot and downstream impact of a clot is a lot worse than a potential bleed due to an operation or something going on in the mouth that can be stopped through various mechanisms that you guys utilize to prevent bleeds. So usually these are continued unless they're significantly really at high bleed risk. But the risk just doesn't outweigh the benefit of stopping it. For both antiplatelets, so we have our antiplatelet options and our anticoagulants. And so the mainstay, the long-standing anticoagulant we used to use all the time, or anybody, because that was all we had, was Warfarin. Warfarin is rat poison. So just a little FYI, it was created by the University of Wisconsin as rat poison. And then we found out, and it still is utilized today as coumarin, and it was still, and Coumadin, and we still use it today in rat poison, but we found out that it thins blood and that we can use it in humans to prevent clot formation. Through inhibition of various clotting factors within this pathway, it inhibits a number of these factors that prevents clot formation. And this is largely used in atrial fibrillation or DVT to prevent the further development of clots if they've had them in the past, or if they haven't had them, prevent them from occurring. And this is measured by the INR, so the International Normalized Ratio you may have heard of before. Typical range we try to keep people in is 2 to 3 in their INR. Somebody with non-anticoagulated blood, you or I, if you had your INR checked, it would be 1. So the higher the INR, the thinner the blood, and potentially the greater bleed risk. However, there's a big window at which bleeding becomes a concern. So you can get a really high INR before you're overly concerned about like major complications from bleeds. However, as soon as you get below 2, and you get in between that normal INR range and 2, 1.5, 1.6, 1.7, your risk for developing a clot significantly increases. That U-shaped curve, there's very little, very narrow therapeutic window below your therapeutic INR, which is why also anticoagulants are oftentimes continued during even pretty moderate dental procedures, even more significant bleed risk dental procedures, because as soon as that INR dips below 2, the risk for a clot really increases. And then if they stroke out because that medication was held for even just that short amount of time, could be pretty impactful, as opposed to having just a little bit of prolonged bleed following a procedure where it could be stopped through some mechanical measure. Just might take a little bit more time. They're not going to bleed out likely from that oral procedure. So historically, you used to discontinue, I say you as the royal you, we used to discontinue warfarin, I think, a lot more frequently, and other anticoagulants a lot more frequently than we do now for procedures, because bleeding, is the major side effect when we're working in someone's mouth. And our last options, our newer anticoagulants, are our DOACs or NOACs, novel anticoagulants. These don't require INR monitoring. They work much faster than warfarin. They're very specific to the factor at which they inhibit in this clotting cascade, but their downstream effect is ultimately the same. They prevent clot formation. So they do have, so they still have the same bleed risk as warfarin. The only upside is that they're much faster onset. It takes warfarin 5 to 7 days, sometimes to reach full effect, whereas these will reach effect within a few hours to days. And so fast on, fast off. Sometimes it's easier to stop these newer medications during an operation, get something completed, reduce somebody's bleed risk and then start it back on. But again, more often than not, these are just continued. And if bleeding does occur, they're managed as needed. This, I need to remove this part, downside limited reversal agents. There's more and more reversal agents for these coming about, which is nice. I didn't mention with warfarin, but the reversal agent for warfarin is vitamin K. So it's a vitamin K antagonist, which is a component in the pathway. And so if you want to reclot the blood for somebody that's on warfarin, you give them vitamin K. And then that will clot it back up and reverse the warfarin. Also used if folks are over anticoagulated or they overdose on warfarin. So as I mentioned,
sorry to interrupt. Isn't that something they use like in labor and delivery too? Like if a woman is after birth?
Yep, exactly. Yep, same thing. And it's the same thing. It's to help the clotting cascade. So you give vitamin K to the baby as well, following delivery, and that just kind of helps to kind of supplement and kick on the clotting cascade, not in a way where you're going to be negatively forming clots, and that doesn't really happen. You can supplement with vitamin K on a daily basis and you won't necessarily be hypercoagulable. But it does reverse the effects of warfarin, since it totally blocks vitamin K's activity. Yep, it's a good question. So yeah, I have this, the second bullet point here: multiple tooth extractions considered high bleed risk, could warrant short-term discontinuation. But as I say, that's kind of more and more falling out of favor, even if it's like greater than 4 teeth being removed. Now I suppose if we're talking about like major jaw operations, where we're really, maybe breaking jaws or open things up, like then sure, maybe we're reconsidering, because significant surgeries, other surgeries, not in the mouth, folks have to discontinue anticoagulants to reduce their bleed risk. But at that time, they might be bridged to heparin, which can be titrated and dose adjusted and kind of turned on and off much more rapidly and easier to control than some of these other options. And so they'll do a little bridge to keep them anticoagulated, but also safe, I guess. And that is all. And I think that's right on time. Right on time.
That's awesome. Thank you, Dr. Berger. Does anyone have any final questions? I know that's a lot, and we did kind of get a little mixed up. Usually I do like to get the pathophysiology to them first, but there's just a lot of content, and they had an exam last week, and it's just kind of been a bit much. So we got a little backwards, but I think a lot of that will sink in, and they can rewatch the recording.
Yep, rewatch, and you can shoot me emails as you need, and I probably go into way more detail than you even need to, worry yourself with. But now
now you know. Any questions for him before we let him go? No? All right. Well, thank you so much. We really appreciate your expertise.
Absolutely.
We'll give you a nice hand, even though you can't see the class.
Yeah.
32 smiling faces.
Oh, that's is that usually how big it is?
We're 32. Yep.
Great.
I know.
Well, hopefully I'll be able to be there again next year in person. Much rather be able to talk to you guys and answer your questions more freely. But,
yes. Well,
yeah.
we'll definitely try to hit you up for it. So thank you so much. And I hope everyone feels better.
Yeah. Thank you.
Okay. Take
All right.
care.
Bye.
Bye-bye. Okay, so I know it's a lot. I know everyone's like, "Woo." So here's the deal. That's all I'm gonna say. I'm gonna let you guys go early today, but I want to get a few things said first. His information is really succinct and it's all really important. So next week, there, if you notice, if you look ahead, there is a quiz on cardiovascular. All that's going to be on cardiovascular is my pathophysiology PowerPoint, which I will get the recording up. It's probably not until late today, maybe even tonight, because I literally have stuff until 4. And so I don't have an opportunity to get it up. And I'm not done. I started the recording and then a meeting started and it kicked me off of my Zoom. And so I only have half of the recording done. So, but next week, so your quiz will be on my PowerPoint pathophysiology. We haven't, it's there, you can look at it, but you haven't heard a recording and I haven't lectured on it. So I'll upload a lecture for it by the end of, I'll say by tomorrow. And then, so you'll have to listen to that. It'll probably be 20 minutes, maybe. So you have to listen to that. So that's what the quiz will be on, plus high blood pressure medications only. And what I really want you to focus on are those suffixes. So I want you to be able to identify if I give a medication that ends in alol or peen or a sartan or the calcium channel blockers, ACE inhibitors, I want you to be able to recognize by the suffixes. So I'm not going to necessarily pull like one out and be like, what's the blah, blah, blah. But in general, when you're as a clinician, you'll be able, and this kind of stuff will very highly likely be tested on the board. They love high blood pressure meds because it's ubiquitous. Everybody practically is on a high blood pressure med. So that's what I'm going to test you on. So that narrows it down. And so it's basically, you're going to be tested on identifying the medications by the suffixes. So if it's an OLOL, you need to know it's a beta blocker, blah, blah, just like that. So that's how you're going to be tested. And then the pathophysiology. And the pathophysiology is about 30 slides. And it basically just says coronary artery disease. What's that? Well, that's atherosclerosis or plaque buildup. What's high blood pressure? Well, it's increased volume. So it's the overall ideas of what the mechanisms are. And I'll do a recorded lecture, but increased blood volume increases blood pressure, that sort of idea. Yes.
The other 2 pipelines of this, are we going with those? Or
you mean there's a are you saying that you see a mini one and then yeah. So there's one that's called mini presentation. Is that what it says? Here, let me just pull it over here. Yes. Oh, I can't minimize it. Hold on.
many on the other one.
Yeah. So, okay. So just so that you guys know, we're all looking at the same thing. So this is just from last year. These were questions that students got wrong. I just left it there for like added information. It shows like questions that were commonly missed last year. And so I just thought, well, I'll just leave it there. It could be a resource. This is what John went over today. And then this PowerPoint, cardiovascular PowerPoint, this is what I'll upload a recording for. And what you'll primarily be quizzed on next week, plus the suffixes for high blood pressure. And then this mini presentation is pretty much the same thing as what you have in here. I just synthesized it a little bit. So I'm not going to specifically test you on that, but it's the same content as the other one. It's just, I wrote it sort of more like an overview. It's like a read through, like, okay, you get the PowerPoint with all the information, and then that's just, I kind of restate it and sort of summarize it. So it's not new content, it's just presented in a different way. And I don't know, I made it several years ago and I just stick it in there. I don't even remember really why I made it, but I did. Yeah.
So for the medication, the hyper.
Hyper blood pressure, hypertension.
Even for the test, we need to know all the.
Basically, for the quiz, for the test, you're going to need to know
Everything.
all the medications. But I'm trying to make it a little bit less stressful because I know, you know, I don't want to ignore the medications for the quiz, but it's in a week and you still have to watch a lecture. It's just, you know, I'm trying to make it a little easier. So instead of just saying, you're gonna get tested on the meds, I'm just narrowing it down to, I want you to be able to identify those drugs based on the suffixes. Because when you're in clinical practice, that'll come to you all the time. You like see somebody on propranolol, or you'll see somebody on a calcium channel blocker, you know, and like lisinopril or something, and you'll automatically be like, oh, I remember in general what that medication is and what it's for. And a lot of times it's based on those suffixes. That'll trigger in your mind. And I know they ask stuff like that on the national board. They love high blood pressure medications on the national board. So that's why I'm focusing on that for the quiz.
And do we have a paper that we have all the medication? Remember?
Yeah, so
Well,
for this course, you have this summary of drugs to know for this class. So this is what I was like, you know, you can take this and you can make flashcards. All of these medications are up for grabs to be tested on. So I'm like basically trying to like keep myself to just this, like, because students would always ask me, what medications do we have to memorize? What medications do we have to memorize? And it's hard because I want to say, well, anything that's presented in the class is up for grabs, really. But so I'm trying to make it a little bit easier for you by saying, this is it. And if you look at it in one document, it's way overwhelming, but that's for the whole semester. So if you take it section by section, you know, it's a little bit easier to digest. And so like what I've recommended to some students, I'm old fashioned. I think of like literal flashcards because that's what I used when I was in school, was like literal, but you have different ways of doing it, but you would just keep adding to your flashcard pile as you're learning more medications. And that's just one good way. This is like what they call rote memory, which is just basic memorization. It's just regurgitating information. I mean, it's one of those classes where, you know, you just have to memorize what it is. It's black and white. You just have to memorize it, regurgitate it. A lot of it flukes away, but a lot of it stays too, because there are clinical applications. Like knowing that calcium channel blockers cause gingival enlargement is like something that will reoccur throughout the whole rest of your 2 years on various quizzes and exams, and it will almost likely show up on somebody's national board. So there are things like that that you want to memorize and know for the long term. Yes, but yeah, Lexicon is always going to be sort of like your backup because there's too many medications to memorize them all. Yeah. So that's what I wanted to say. There will be a lecture up for the pathophysiology. That will be the quiz next week, plus the suffixes for the high blood pressure medications. And then I'll post this one right after I get it up on YouTube, and then I can post it on. All right, so that's it. Do you guys have any questions at all besides that? If not, you are free to take a little bit longer break before your next class. I'm going to stop this Zoom recording.